My name is Emma. I am a fourth-year medical student, and I've been with you guys a few times. I was here, I think it was 2 weeks ago, where, what did we talk about 2 weeks ago for those of you that were here last time? Oh, great. Thanks, Madeline. Thanks for reminding me. We talked about diabetes. Which I hope was of benefit to you all. Today we're going to talk about, something that is perhaps relevant to now, relevant to COVID. We all love our lungs now, especially in the COVID era. So we're going to talk a little bit about restrictive and obstructive lung disease today. And if you don't know what those words mean, that's perfectly okay. By the end of this, I hope that you can kind of categorize these things. And when we talk about restrictive and obstructive lung disease, we're going to use, words that you probably know, like COPD and asthma. So we'll certainly talk about those things today. And as always, if you guys have any questions at all, feel free to put them in the chat or unmute yourself. If this is your first time with us, welcome. We're certainly glad to have you. I just put the link in the chat there that has some resources for you, like the SOAP note that you'll fill out throughout the presentation, as well as the quiz and some other resources that may be of benefit for you for this presentation and other ones. As always, please visit our Motivate MD YouTube page, hit subscribe. And in the event that you can't come to this live, if you are an East Coaster like I, and it's past your bedtime, too late for you, you can always watch it back, once the session has been recorded and uploaded later. So go to that link and you can click subscribe. And if you ever have any questions for the presenter that you may have missed, or something that was interesting, or you want to tell them that it was a great presentation, please do. Please comment on our videos and hit like, all of those things. We would certainly enjoy all of that. All right, so the recommended read today is relevant to what we're going to be talking about. One of the things that we're going to talk about today is COPD, which falls under obstructive lung disease. So this brief read, the link is there, but it talks a little bit about this kind of mental health aspect of COPD. So it's a little bit more relevant than some of the other reads I put up there for you, but it's a quick one, especially if you like reading sort of scientific, journal articles. This is one you can certainly look over, okay? All right, and because I didn't have anywhere else to put this vine, and I wanted to include it, and I hope that you guys are as thankful for my presentations and Motivate MD's efforts for you guys as this little guy is of this avocado. Let me play it for you. Yeah, it's my favorite vine too, Madeline. I think it's like the best vine ever. And I came across it this weekend when I was making this PowerPoint for you all, and I was like, I have to put it in. There's no reason not to. So with that being said, let me start the poll here for you. And as always, be honest and go ahead and put your answer in there in terms of what you know about restrictive and obstructive lung diseases. All right, so I think a few of you are missing. I'll give a couple more seconds here so you guys can kind of zoom in there. All right, so we'll stop it there. It looks like the majority of you guys are kind of on the side where you may not know a lot about restrictive and obstructive lung diseases, which is perfectly fine. I don't mind that at all, and that's what we're here for. So I'm gonna, as always, or my intent is to try to make this as the least amount of stress as possible, because this is not supposed to be stressful for you guys. And a lot of the topics I inevitably cover are complicated topics. So I'm going to kind of keep it at your guys' level. And if anything doesn't make sense, please ask. You know, don't feel like any question is dumb. The reality of it is probably other people are thinking the same thing. So ask your questions. Feel free to type them in the chat or ask them out loud. Okay. And here this is, I didn't share it with you, but it looks like the vast majority of you said I know nothing, which is okay. So let's see if we can't change that for this presentation. Who wants to play the Vine again for you guys? All right, so in terms of the session outline, as always, we are going to kind of go through the case, walk through the physical exam, we'll go through some details, we'll talk about the differential diagnosis, and then we'll talk a little bit about the pathology itself. Slightly different from the last few times is I've included a little bit of the lesson within kind of the case at certain points, because I think it might be easier for you to understand right when it's happening instead of remember 5 slides ago when we talked about this is what this is. As always, feel free to participate, ask questions, fill out that SOAP note form in order to get credit for this session. And then please give any feedback that you see fit at the end of the presentation. Here's the SOAP note form. I put that in the chat. So for those of you that missed it, I just put it again. It's the SOAP note form that you'll fill out. Subjective is the things of which the patient tells you. So like the HPI and the review of systems, so pertinent positives and negatives. Then objective is things that, you know, we as providers, you know, find or discover or based off of our examination. So it's things like vital signs, things from our exam that will all go into objective. And then assessment and plan will kind of rank our, you know, what we think is going on with the patient, and then really lay out a plan of what we're going to do about that differential diagnosis. Okay, let's get started with our case here. This is a 31-year-old male that presents with a 2-week history of increasing shortness of breath. He notes that he's had worsening shortness of breath to the point where he cannot walk but 2 to 3 blocks without stopping to rest. He reports decreased appetite. We call that anorexia, by the way. Not like anorexia nervosa, but it's called anorexia. Nausea and vague abdominal pain, but denies any current or remote history of tobacco, drug, or alcohol abuse, as well as denies fever, chills, cough, or syncope. He denies any specific past medical history and notes that he has been relatively healthy and active up until this point. So my question for you all is, my first question is, what questions should we ask this patient before we proceed doing anything else? What else do we need to know from this guy or from his family, or what do we want to ask? Any ideas? Okay, history in terms of what? What do we want to ask about the history? Yeah, is he on medications? Good, yeah. One of the most important questions that you can always ask is if he's on medications, because you're going to find that a lot of things that that can be caused in medicine, one of the things on the differential is always medications. If we're thinking shortness of breath, Madeline, do you know any medications that can cause shortness of breath? And then in the meantime, other things people have said is what factors worsened? Absolutely. Does he have any chronic conditions? Yeah, so it said that he has no past medical history, but we can certainly ask. Any family history? Good, yeah, that's always important to kind of to ask about. Any allergies? Sure, yeah, we want to ask about what allergy specifically. Remember, when we talk about allergies, we can consider food allergies, environmental allergies, and then allergies to medications. Those are all things, you know, in the realms of allergies. Madeline, the one that I wanted to see if you knew was amiodarone. Amiodarone, when I talked about something else, I talked about amiodarone, but it can cause I think I talked about it when I talked about thyroid disorders is what I think because I did talk about thyroid disorders. Amiodarone can deposit in the thyroid tissue, causing hypo or hyperthyroidism, depending. And then also similarly, it can deposit in the lungs, causing shortness of breath. So that's one thing we want to consider. You're absolutely right about medications. Anybody else? Any other questions you want to know from this guy before we go on? And then now, what important differential diagnoses do we want to consider? And I added this in now because I want you guys to think broadly. I want you to kind of have these sort of broad thought processes so that we can narrow things down and that we don't forget anything, okay? So go ahead and throw things out, things that cause shortness of breath. And I will give you a clue that I've taught one of them, and it wasn't that long ago, I don't think. I think I taught it in July. Yeah, we always put COVID on the differential now. You're absolutely right. So pneumonia, TB, pulmonary edema, perfect. Asthma, good. Yeah, absolutely. Anything else? What about if COPD? Sure. What about if this was a young female and she was on birth control pills and she had a predisposition to clot? Yeah, exactly. What kind of thrombosis? So we're talking about clotting. Yeah, pulmonary embolism. That's exactly right. Anything else that we want to consider? This guy has nausea. He has decreased appetite. What else do we want to consider when we think of those kind of broad symptoms? Viral, sure, yeah, absolutely. We can think infectious disease. We can think of nausea, cachexia, things like that. Anorexia. We would want to think HIV/AIDS. Certainly, these sort of systemic viral infections. There's one thing that I want you guys to think of. Stomach, yeah, we can think of other infectious disease causes. He's young, yeah, we can think MI. Sure. There's actually two things I want you guys to pinpoint. It's also along the lines of cardiac as well. What if he had lower extremity edema? He was short of breath. He looked fluid overloaded. Good job, Madeline. I think you came to my lecture about CHF, and I'm glad that you got it. Now, there's one other thing that I want you to think of. What about if this patient was maybe older? The smoking history doesn't matter so much for this, but had lots of weight loss over time. Our patient didn't have necessarily weight loss, but we know that our patient, yeah, we want to think cancer, sure. And the thing about lung cancer is we want to think, obviously primary lung cancer, meaning it originated in the lungs, but we also want to think about metastases from other areas. Lots of things love to metastasize to the lungs. Lots of things love to metastasize to the liver. So good job with the differential here. I think we pinpointed a lot of things here, not just pulmonary causes, but cardiac causes and infectious disease causes. So good job with that. Okay, and what elements are important from this guy's history, other than the things that were bolded, or in addition to? What do you guys remember that is important that was written in the history? What about his profession? Hey, yeah, that's a great question. And I often emphasize that as well. And for once, I didn't put that in the vignette this time. But yeah, we can certainly ask about what this guy does for a living. And why do you want to ask about that? So no fever of chills, so not likely infection. Yeah, but we can still follow that up. Yeah, because we know sometimes patients won't show signs of, fever, chills, alterations in their vital signs, but may be septic. All right. Anything else that was important from his history? There's something from his social history that I want you to hone in on. Yeah, good job, Jocelyn. He didn't use tobacco, not now and not in the past either. So it's important to remember when you ask about tobacco that we don't just want to ask about, do you smoke cigarettes? We want to ask about, have you ever smoked cigarettes? You can, and when I ask the question, I often say, do you smoke cigarettes or use tobacco products? Because remember, there's also, smokeless tobacco, things like that. If they say no, then you can follow that up with, have you ever? Or sometimes they'll divulge that information anyway. Okay. All right. So in terms of the physical exam, what parts of the physical exam do we want to pinpoint? And we'll kind of make a list here of things that we want to pinpoint on this guy's physical exam here. Yeah, we want to listen to the lungs, sure. And definitely breath sounds, you're right. Yeah, we want to listen to the heart, sure. Anything else about the heart that we want to pinpoint? Anything else? Yeah, we can check for murmurs. Good. EKG? Sure. We'll see what his vitals are if we have an indication to get an EKG, for sure. Anything else that we want to pinpoint? Obviously, part of our physical exam is always this general appearance. So that's kind of just your assessment of the patient. Yeah, check for edema, good. And we can check the abdomen, certainly. And I think perhaps you're getting at in terms of the abdomen, they might have, ascites, they might be fluid overloaded, and that might be signs for us that, this patient has a low ejection fraction and they have a cardiac problem. Good. All right, we put skin. Sometimes people include edema in the heart exam. It just depends on who it is. Anything else you guys want to pinpoint? All right, I'll take that as a no. Oh, temperature, yeah, for sure. We're gonna check the vitals, and here you go. Here's the temperature for you. It is very unremarkable. It's underwhelming. It's 98.2. He is tachycardic, blood normotensive, normal blood pressure, and a little bit of a fast respiratory rate. But other than that, the patient is well groomed but cachectic appearing, with prominent temporal wasting. Okay, so what that means is basically there's a picture over here. Here's our guy over here to the right. And what the arrows are kind of alluding to here is kind of this loss of muscle, of the temporalis muscle along the skull here. So you can basically see the sort of prominences of the skull there. And probably for you and I, you wouldn't be able to really see that on us because we have a prominent temporalis muscle, for a lot of reasons, because we're talking, we're eating, we're chewing, doing all these things that need, that rely on the temporalis muscle here, in addition to our other jaw muscles. Also, he has a little bit of muscle wasting here, as you can see. But other than that, let's listen to this lung exam and let me know if you can't hear this. I hope that it works because it's a good lung exam. Let me play it again for you. So somebody out there, let me know, what are you hearing here? Any guesses? Anybody that is probably an EMT out there may know? Yeah, wheezing. I think Madeline is an EMT. That's my guess. Yeah, good. So so we hear a little bit of wheezing, and what we call that is both inspiratory, so when the patient breathes in, and expiratory wheezes when the patient breathes out. So that's how we kind of delineate it, because inspiratory and expiratory wheezes can, depending on which one's present, can lead us one way or the other in terms of our diagnosis. Yeah, some fluid buildup, absolutely right. and what we call that is rails. So we hear a little bit of crackles. And then the other thing is if we hear kind of the snoring noise, that's what we call rhonchi. But we didn't really hear a lot of that. It was a little bit more, the lungs sounded wet, and then it sounded like there was some wheezing there as well. So good job. Wheezing sounds, exactly like what the word, like if you were to think of what wheezing sounds like based on the word, it sounds like, what it is basically. So you guys got that spot on. Good job. Other than this, in terms of his HE and T exam, he has moist mucous membranes, so doesn't look too dehydrated from that. He's tachycardic, but has a regular rate and rhythm, so no murmurs, rubs, or gallops are there. He has a barrel chest present. And what we see is, kind of, it looks like the patient is kind of in this chronic expiratory phase where their chest looks kind of puffed out. That's what a barrel chest is. He's breathing through pursed lips, so kind of like this, where he looks like he's constantly breathing out. And then prominent expiratory wheezes heard throughout. In terms of the abdominal exam, there's some abdominal tenderness throughout, a little bit worse in the right upper quadrant, but no masses are present. So a little bit of abdominal tenderness. Other than that, that is the extent of our examination thus far. So let's go on to our lab values here, and we'll kind of dissect these together. In terms of our CMP, it's fairly unremarkable. So we see here that it looks like the sodium is okay, our potassium's okay, chloride's okay, our CO2 is all right, BUN is fine. So basically we're looking at these are our electrolytes, BUN and creatinine, that's for our kidneys. And then our glucose looks okay too, which, obviously is vastly different than the last time I talked to you when we talked about diabetes. That patient's glucose was very, very high. All right, let me clear all that. And then the other thing we see is the ESR is high. So what does the SED rate tell us? Does anybody know? Anybody out there know what the SED rate tells us? So what we do is we drop some blood into a tube and we wait until it kind of falls down based on the tube. We measure that over an hour, and then the measurement in millimeters for the entire hour tells us that's exactly right. It tells us how much inflammation. It doesn't really tell us a lot. It tells us that there's inflammation there, and that's really about it. So it's a very non-specific test, in other words. So other than this, we got a blood gas, and I talked to you a little bit about blood gases last time, and I hope that I didn't confuse you too much last time with blood gases. So let's start from the top. For those of you guys that were here with me last time, here's our pH. Is our pH, do you remember the range for our pH, anyone? It's okay if you don't. Yeah, good, Madeline, perfect. So our normal pH is around 7.35 to 7.45. And when things are below that, we say the patient is acidotic. And when the patient is above that, the patient is alkalotic. This is bringing back all of your beloved chemistry, general chemistry that I know you guys all love. So based on the patient's pH off this blood gas, is our patient acidotic or alkalotic? Perfect, acidotic, perfect. Now, our PO2, we generally want that in what range? Do you guys remember? We usually want that around 80 to 100. And then our PCO2, so obviously we are a little bit hypoxemic here. Our O2 is low. And then our PCO2, which is a surrogate of what? When we look at the PCO2, we say that this number tells us about what organ is doing. hope that question wasn't too confusing for you. Good, yeah, the lungs, you're absolutely right. And then our bicarb tells us what organ is doing alternatively. Yeah, good. And then here's our bicarb. And we'll say that that's a surrogate for the kidney. All right, perfect. So when we talk about CO2, we say that a normal CO2 is, 35 to 45. Ours is 49, a little bit high. And we know that CO2 is an acid. So we know that our respiratory acids are high. So we know that our CO2 tells us what our lungs are doing. And as a result, we know that there is a respiratory acidosis, okay? We don't have a lot of compensation here for the bicarb. It's in a normal range. Our normal is 22 to 24 roughly. So we know that we have a respiratory acidosis here, which makes sense, doesn't it? Unless the patient is compensated in that the patient's breathing fast and very tachypnic and blowing off lots of CO2, that might be a compensation mechanism for, a patient trapping air in their body. But for right now, we know that we have a respiratory acidosis. Let's leave it at that. And then I know some of you guys were really set on getting a CBC. Is our white count normal? It's not a trick question. I trust you. Good. Yeah. Our white count is normal. Yeah, you guys are right. So it's in the upper right-hand corner here. It is normal. Normal goes, anywhere depending on the lab, anywhere from like 11 to 12. It's like 4 to 11, 4 to 12 range. Okay. Our hemoglobin is normal. Our hematocrit's normal. Our platelet count is normal. So we don't have a lot here. We got a respiratory, we got a sputum culture. Maybe because this patient was coughing, we thought they may have some sort of lung infection going on. So we got a sputum culture that showed mixed flora with predominantly macrophages. When we say that there's mixed flora, that's an underwhelming culture result because it may tell us that, nothing really specific is growing there, in other words, okay? So what is the normal range for PCO2? 35 to 45, roughly, okay? What other imaging do you guys want to get, or what other testing? We'll say, what other testing do we want to get? Anything? Are we ready to, yeah, what kind of x-ray? Chest x-ray? So the culture means normal but inflamed. So there is some macrophages there, but remember, macrophages can be resident to the lung parenchyma, the lung tissue. So seeing them isn't sort of pathognomonic for anything because we know that we have immunological cells that are sort of native to the lung tissue. So this tells us really nothing. There's mixed flora, meaning there's normal, it could be normal flora of the lungs there. We didn't grow one specific pathogen. So this is basically a normal culture, basically, okay? Chest CT, sure, we can certainly get a chest CT. Lung function test, yeah. Do you know what that's called? Close. It's very close, and we'll learn a little bit more about that in the future here. So here's your spirometry. Good. So here's your chest X-ray, and we can kind of read this together. I won't ask anyone to read it because it can be certainly challenging for anybody's level here. The way I like to do it is by this mnemonic, and anybody that you ask might teach you something different, is A, B, C, D, E. So when we say A, what we're talking about here is our airway, Okay, so when we're looking at our airway, we're looking at the big, windpipe in your body that, takes air obviously from your mouth and your nose and, takes it down to the lungs and then bifurcates to form your right and your left main stem bronchus. So what we're seeing here, and it looks pretty good in terms of the trachea. Let me get my pointer here so I can show you. All right, so what we're seeing, the trachea starts here. Okay, so here's our trachea. And you can kind of see it really, sometimes it could be hard to discern here, but it looks like, to me, it bifurcates around here. Okay, so when we're looking at a chest x-ray, we have to remember the patient looks like they're facing us. Okay, so our right is their left. So this is, this would be left here, and this would be right. And so this would be correspondingly our left main stem bronchus here, and then our right main stem bronchus. And then we see that it branches into the pulmonary vasculature there. And then next we look at breathing or bones. So we can kind of count ribs to make sure that the patient had a good inspiratory effort. We know that if there's not a lot of ribs showing in the chest x-ray, that it might have been a poor inspiratory effort and decreased lung volumes. But for this isn't the case. We see, a depressed diaphragm down here. This is our diaphragm. We see a skinny cardiac silhouette here. And then ABC, we can talk about circulation. So we can talk about the pulmonary vasculature, which we talked about briefly, and the obviously the heart. Usually we see the aortic knob around this area. D, diaphragm. So we talked about that. And really, that's about it for this X-ray. We see primarily that the lung field or the diaphragm is depressed. And what we see is a skinny cardiac silhouette. So we know, perhaps something is going on here pathologically. All right. All right, so next we did get a spirometry test, and I'm going to show you later what exactly this means. Because what we're doing is we're testing the lungs' ability to obviously take in air and then, expire air, so blow all the air out. A, B, C, D, E, I'm totally blanking right now what E is. I'll think of it. But in the meantime, for the PFTs, really what we're going to do is measure the lungs' ability to take in air and then obviously expire that air as also. So for this PFT, what we're looking at is a few values here. Okay, I just thought of it as I was talking. So E is for everything else, which is non-specific and probably why I didn't remember it right away. But it's just everything else in the chest x-ray, and usually why I skip over the E. But so you're looking at just the other parts of the x-ray, making sure the patient's not rotated, making sure it's a good film, making sure that it's not under-penetrated or over-penetrated in terms of the radiation, stuff like that. Sorry, I didn't think of that right away. So what we're looking at here is a few values. This chart is graciously marked in red here. So we're looking at the FEV1. So the FEV1 is the forced expiratory volume in 1 second. So it's measuring here. This is the flow on the x-axis, or I'm sorry, the y-axis. And then we're looking at time on the x-axis. So what we're seeing is how much the patient can expire, how much of their lung volume they can expire in 1 second. And really for obstructive and restrictive lung diseases, we're looking at this FEV1 to FVC ratio, okay? And what we notice here, a normal FEV1 to FVC ratio, and the forced vital capacity is how much, you can, with a forced expiration, blow out of your lungs. And a normal FEV1 to FVC ratio is usually greater than 80%, okay? And what we see when we talk about an obstructive pattern, when we say obstructive, we say that that is less than 70%. When we talk about restrictive, we say that that is greater than 70% generally, okay? And we'll talk a little bit why that happens later on. And then the total lung capacity, that sounds exactly what it's like. How much air, your lungs can hold at maximum. And then residual volume is after a forced expiration, how much volume stays in your lungs, okay? And then the DLCO is the diffusion of carbon monoxide. And what we see and what we kind of generate here is the spirometry curve. So when we talk about tidal volume is this volume that you breathe comfortably. So when you and I are breathing, if you are just breathing comfortably, what we are breathing in essentially is your tidal volume, okay? So that's what we see on this curve over here. I'm trying to pull out my pointer for you guys. So what we see is this here. So when you're breathing in comfortably, this is what you breathe. And then when I tell you take a deep breath, so you guys all take a deep breath in, that's what we see here when we go up. That's the inspiratory reserve volume, how much you can breathe over your tidal volume to fill up your lungs, okay? Then when I tell you to forcibly exhale that, then what we see is the combination of the inspiratory reserve volume, the tidal volume, and the expiratory reserve volume. So how much air is left in your lungs when you exhale forcibly. So your expiratory effort obviously is there. What we see there is your vital capacity. Then, as I kind of mentioned before, the residual volume is how much is left in your lungs after you exhale forcibly, okay? And then all of these values combined is your total lung capacity. So again, we'll kind of go over this one more time so it makes a little more sense. So when you inhale or when you breathe comfortably, you just sitting here watching me talk to you, you're breathing in and out your tidal volume. That's usually around 500 milliliters. So here it is. This is normal. I tell you, okay, take in a deep breath. You take it in. That's your inspiratory reserve volume, is that amount of air that you can breathe above your tidal volume. Similarly, the amount that you can breathe out below your tidal volume, so exhale, is your expiratory reserve volume. And then the vital capacity is your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume combined. Okay, then the residual volume is no matter how hard you try, your lung is going to have a volume in it. That's your residual volume. So by definition, that makes sense. The residual amount of air that's in your lungs is your residual volume. Okay, so that's those. I hope that was, as clear as mud for you to kind of make sense of. But what we see is we kind of form, based off of these values, we form these curves. So what we see is on this curve on the right here below our spirometry curve, we see this diagram that's made based off of spirometry is, so what we'll see is obviously time and flow is going to be on different axes. So when you take in it, remember whenever you, this is basically your expiration up here. So you're expiring this way and you're inspiring this way. All right. So if we start at this point, when I tell you take a deep breath, and you take in this volume, that's when we're at this point here. Then I tell you to breathe out forcibly as fast as you can, and we take that measurement in 1 second. That's our FEV1, okay? And then how much you can forcibly exhale in general is your FVC, and that's the ratio that we're looking at. And as you can see, this is a normal curve here. All right, and then when we look back over at this, we see that this is a not so normal curve. Okay, we see a decreased FEV1 to FVC ratio. We see in 1 second, this guy is not breathing out a lot, as you can see. I hope you guys can really see that from here. What we should normally see is, okay, this guy takes in a deep breath. Okay, great, great, great. Then we say, okay, blow out the birthday candles as hard as you can for 1 second. And what we see at time 1 second, which is right here, he doesn't really breathe out a lot. You know, we should see kind of something like that is going to mirror that curve that we just looked at. Okay. I hope that this makes a little more sense. So the main information that we want to take away from this is the FEV1 to FVC ratio is low, which is also kind of demonstrated by this curve. Okay. Does that all make sense to you guys? Give me a yes, no, a maybe. Let me know where you guys are standing with this. I know this is a lot of information. Okay, good. Makes sense. Perfect. If you guys have any questions, let me know. We're going to kind of go back over this again at the end when we talk a little bit at the end about the pathology itself. Okay. So let me clear all of this mess that I have made here, and we'll go on to the next slide. So here's the pulmonary function test again. This is the same thing that I basically just said. So I'm going to leave this slide for you guys to review on your own if you need a reminder of what these definitions mean, or if you know it makes a little more sense to you in words. All right, and we can go back to the slide if anybody has any questions later on as well. All right, so my question for you guys is, do we need a CT scan? Do we need a biopsy? Looks like he's breathing in more than out. Where does the air go? Exactly. Great question. And that's exactly what we're going to talk about in this pathology when we talk about obstructive lung disease. The air is trapped. You're getting air trapping. Remember when we said back here, so remember 2 times I'm going to remind you of where the air is going. And it's not a silly question at all. It means that you're thinking, and I like that. Remember this? He has a barrel chest. Now you tell me, where's the lung going? Or the air going, rather. And then same thing with this. Look how increased these lung volumes are. I should have put a normal chest x-ray right next to it, but these are big inflated lung volumes, okay? So we see the costophrenic angle down here. It's not blunted. There's no fluid down here. So Madeline, you tell me, where's the air going? It's kind of a trick question. Yeah, it's not going anywhere. It's trapped in the lung. So we're getting air trapping here. So that's a great question. I'm glad you brought it up. All right. So my question for you guys now is, does this patient need a CT scan? Does this patient need a biopsy? What do you guys think? You wouldn't be wrong either way. What about in terms of the CT? So here's our CT. So we kind of see, you know, this pattern of you know, air trapping in here. Obviously, we see, you know, obviously it'd be easier to look through kind of the cuts of the CT to make a little more sense of it. But in terms of obstructive lung disease in general, a CT scan is not absolutely indicated for this. So, we don't absolutely need it. The reality of it is we can diagnose the patient with what we think they have based off of the spirometry results and probably the CT. So, really, the indication for a CT is if you're going to do something, or you're going to do a intervention with the results, like if you're doing different thoracic procedure with this in terms of the lungs, or if you're suspecting a pneumonia or something, some other pathology that couldn't be seen on X-ray, or you need to see the parenchyma better, any of those things. All right, so what about a biopsy? What are we biopsying if we are? Remember that the lung is essentially a balloon. Are we sticking a needle into the lung to biopsy the lung? We know that the lung is kind of the problem here. And we know that from the CT that we're kind of getting some, a little bit of ground glass opacities here. All right, in terms of the biopsy, let me remind you that this patient is young. So this is a young patient, no past medical history. And what we want to do is find the etiology behind this patient's, COPD, behind the patient's shortness of breath. We want to look for genetic causes. Does anybody know out there a genetic cause of shortness of breath, of COPD in patients who have no past medical history, who have no smoking history? So what we want to do is biopsy the liver. If we have a suspicion that the patient has what we call alpha-1 antitrypsin deficiency. And we're going to talk about the pathology behind that, but what we're seeing here, due to the polymerization of this protein, of which is made in the liver, by the way, synthesized in the liver, like a lot of different proteins, like albumin, like different clotting factors are synthesized in the liver. But what we're seeing here is these little globules are getting trapped in the liver because they polymerize and get trapped there. So when we do a liver biopsy, we can see that very clearly. Obviously I didn't expect you to make that jump at this level, but that's something to keep on your radar when you know this history. So this was kind of a tough case. Should it not have started earlier than 32? It certainly could have. It depends on if the patient is homozygous or heterozygous for that gene. So what we see is patients who are homozygous certainly get it earlier, especially if they do something like smoke or have, environmental exposures, or work in a coal mine or whatever. If they're heterozygous, it can, onset later in, the 30s or whatever. Maybe this patient had a precipitating factor which exacerbated this, or, has always had shortness of breath and never sought medical care for it. So this was kind of an acute presentation of this, perhaps acute on chronic. All right, so our differential diagnosis, what are we saying this guy has? You can make it rather general if you would like. So yeah, exactly. So the patient has COPD. you guys will learn here in a second that COPD is an umbrella term. COPD itself doesn't mean a lot because when we talk about COPD, we break that into emphysema and we break that into chronic bronchitis. And what we know this patient has is alpha-1 antitrypsin deficiency, which is a form of emphysema. Okay, so we know that, as I just said, there's chronic bronchitis and emphysema. And what we see, as I kind of put this little cartoon up in the upper right-hand corner, is smoking causes what we call a central lobular emphysema, where it primarily affects it affects the respiratory bronchioles, whereas when we talk about a pan-acinar, that's primarily with things like alpha-1 antitrypsin deficiency, where we see this pan-acinar, meaning that it affects the alveolar ducts, the alveoli, and the respiratory bronchioles. So there's a cartoon that kind of shows it. And we know that normal, we kind of see these terminal bronchioles that, branch and form alveoli at the end, which participate in gas exchange. Obviously, when we're breathing in O2 and then exchanging CO2 to be exhaled. And that's all happening at the level of the alveoli and the pulmonary vasculature. Okay, so other than this, we can certainly consider things like chronic bronchitis, but this is less likely. The patient doesn't have a history of smoking, doesn't have, sputum production. We can consider something like asthma, less likely because asthma itself usually onsets earlier, and this patient really hasn't had any history of that in the past, and didn't have this, typical thing that we see, which is this reversibility with bronchodilators like albuterol. Okay. And then, as we kind of talked about before, we can consider something like a lung malignancy. All right, especially with the patient being cachectic, temporal wasting, having a little bit of loss of appetite, anorexia, stuff like that. All right, so assessment and plan. What do we want to do for this guy? Essentially, what we know is that the patient has perhaps an acute on chronic COPD exacerbation. So what do we want to do? What's our first step for this patient? Yeah, oxygen, good, exactly. You're exactly right. And perhaps a flaw of my presentation is I didn't even give you guys an SpO2 in the beginning to tell you guys what this patient's statting. So that would have been a good question to ask for your physical exam. That's valuable information to know. So this is an acute exacerbation of COPD. So we want to give oxygen. Yeah, we want to give supplemental O2. We can try nasal cannula, see how they tolerate that, and see what their oxygen saturations are. Do you guys know what you want to titrate the oxygen to for patients with COPD? The answer is we want to titrate to around 88 to 92% because patients with COPD have a hypoxic respiratory drive. And when you crank up the O2, you're inhibiting that respiratory drive that tells the brain, I need to breathe. So at baseline, they're hypoxic, and that is what causes them to breathe. So we don't want to blunt that by cranking up the CO or the O2, okay? Other than that, let's give bronchodilators. So we can give, nebulizer solutions, things that open up the airways and bronchodilate. So dilate the airways so that we can allow gas exchange. So things that we can consider are short-acting beta agonists. That's what a SABA is, which are things like albuterol. Albuterol is a short acting. When we talk about long acting, those are things like formoterol. You'll realize that it has the OL at the end. And then other things that we can consider are long-acting muscarinic antagonists like ipratropium. And then other than this, we will give corticosteroids. So this can certainly help with gas exchange as well, and sort of this inflammation that's going on with this exacerbation. So we can give things like prednisone. And then we can consider giving antibiotics if 2 or more of these exist, like increased dyspnea, so increased shortness of breath, things like a cough, increased sputum, or other things. If the patient is having a severe COPD exacerbation, we can consider things like non-invasive positive pressure ventilation, like BiPAP or CPAP even. And then we know that if this fails, if the patient is unable to tolerate BiPAP or unable to be switched over to high flow nasal cannula, then and they're kind of tiring out, then we want to consider intubating at that point. Okay. So other than this, so this slide is, essentially the same, but this is kind of another algorithm that we can consider when we're thinking of obstructive versus restrictive lung diseases. Okay, so when we talk about this, we say obstructive lung disease. Okay, FVC or FEV1 to FVC ratio less than 70. Okay, great. And then we look at FEV1. That tells us, that we have an obstructive process. We know that the patient has an exacerbation, and as of 2017, there's kind of this gold classification that tells us, based on the FEV1, what they fall under, and then each of those kind of has, a different treatment for it. Whereas A is the less severe, and B is, a very high risk of exacerbation. So for A, we say low exacerbation, whereas B is very high risk of exacerbation. So obviously we have an escalating treatment as we kind of go along that treatment algorithm. Okay. All right. So let's keep going here. So this slide is essentially the same. It's just a different picture. So don't get too hung up on that. All right, so in terms of definition and classification, the best and sort of gold standard for diagnosing obstructive and restrictive lung diseases is spirometry. And as we kind of talked about, we can get these values, the FEV1 to FVC ratio. And then we can see these other values as well. We can see total lung capacity. If it's increased, we know that we're trapping air. If the residual volume is increased, we know that we're trapping air also, okay? Other than this, we can get a chest x-ray. We can get an ABG, look for hypoxemia, and we can look for increased CO2, as I kind of indicated before, unless they're compensated. Sputum cultures will tell us if there's a superimposed bacterial infection. And then here's that x-ray that we looked at earlier, kind of shows those depressed diaphragms, and shows the skinny cardiac silhouette that shows high lung volumes and lots of air trapping, okay? Alrighty, so here is a video here, and let me mute it because there's really one thing that I'm trying to show you here, and that's what the patient is really doing. So they're connected kind of to this mouthpiece that kind of seals your mouth onto the device. And what the tech is going to tell the patient to do is take a deep breath in, inhale as much as you can, and then blow, 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 blow. And what we're measuring is the FEV1, obviously at 1 second. And then we're also measuring the forced vital capacity, so how much air they can blow out. And that's what's going to give us those values that we were looking at previously. So that's on the video if you want to watch that later, but it's a fairly simple test, but gives us a lot of information. Okay. And then now we're really going to kind of delineate between restrictive and obstructive lung diseases. So for obstructive, what we know is that obstructive is, essentially a limitation or an ability to not get air out. So you have an obstruction to releasing air, okay? And what we know about obstructive diseases is, examples include emphysema, where you have problems at the alveoli level, so you don't have that elasticity to snap the alveoli back and push the air out because they're all blebbed up, as you kind of saw from that cartoon. Chronic bronchitis, we have this increased, mucus and secretion, so we have an obstruction in that regard. Bronchiectasis is kind of dilatation of the bronchioles, and then asthma as well is a very classic example. And then the other side, restrictive lung diseases, is what we see is we have a problem getting air into the lungs. And so what examples of that that we see, these sort of pneumoconiosis, like asbestosis. So whenever you hear all of those examples from the TV ads, when they're asking, all the lawyers are asking if you've been exposed to asbestos and mesothelioma and all these things, what it causes basically is an inability to get air into the lungs. So things like sarcoidosis, problems with your chest wall, obesity, hypoventilation syndrome, those are all restrictive lung diseases. We'll see, because the FEV1 and FVC in restrictive lung disease are both increased, as you know, if it's a ratio, FEV1, if that's decreased, and the FVC is also decreased, what do you get when you decrease the numerator and the denominator? The number, is increased as a result. Whereas for obstructive lung disease, the FEV1 is decreased more. So that's why we see a decrease in that ratio. Okay. So that's how we kind of delineate those things. Other than that, we might see that the total lung capacity, this is normal here. It can certainly be increased because of air trapping. And then for, you can also see an increase in the residual volume as well. So as we kind of see in the bottom right-hand corner, we kind of see that coving here in the obstructive lung disease pattern. We see that the residual volume can be increased, and then total lung capacity can be increased here. And then the FEV1 is, markedly decreased in obstructive lung disease. Whereas in restrictive, it decreased for both FEV1, so the amount you can blow out in 1 second, and for the forced vital capacity, causing a normal to decreased ratio for that FEV1 to FVC ratio. Okay. So I know that was a lot of information there, but so this is, basically reiterating the same thing that I just said, just to kind of drive that point home. And I'm, almost finished here and finishing up, but this is a problem with air trapping. So getting air in. So when we say there's a problem with obstructive, so asthma, bronchiectasis, COPD, so emphysema, that's all problems getting air in. And then when we talk about restrictive, this is all problems getting air out. All right. So this would be things like, hypersensitivity pneumonitis, so being exposed to allergens, interstitial lung diseases, like autoimmune causes, and then also those things like being exposed to asbestos, and coal also is one that is commonly tested as well. All right, so I'll leave you with this slide to, look over on your own, but it's basically saying, there's all of these etiologies to COPD. Here's alpha-1 antitrypsin that we talked about. And then the big one that we talked about, and I probably put this in here because it's colorful and pretty and I like it. But what we see, all of these different etiologies lead to, lung injury, inflammation, impaired lung growth and evolution, which correspondingly leads to systemic inflammation and leads to small airway disorders, which causes, a lack of, obviously an obstruction and inability to get air out, okay? That's basically all this slide is saying here. Then I think this is my last slide here. I think I have one more after that maybe, but in terms of alpha-1 antitrypsin, really briefly, when we talk about the pathology behind alpha-1 antitrypsin, basically what we're saying here is that alpha-1 antitrypsin is this protein that inhibits what we call this protein called TACE. It's kind of indicated here. And what TACE does is results in the chemotaxis of neutrophils. So that's what this is showing here. And this is through second messengers, obviously, but what we see is when alpha-1 antitrypsin is not there, we get an increase in neutrophil elastase. So when this is not being inhibited, when we have no inhibition, we have an increase in neutrophils, and neutrophils are allowed to release neutrophil elastase, which causes damage to the alveoli. So that's why we see kind of this blooding that is shown in this cartoon. So what we see kind of is this normal balance here in someone who's normal and doesn't smoke. We see a normal balance between proteases and antiproteases. So alpha-1 antitrypsin is the antiprotease, and neutrophil elastase is the protease. We see when someone is a non-smoker but is heterozygous for that gene for alpha-1 antitrypsin, we see a little bit of an imbalance here between alpha-1 antitrypsin and neutrophil elastase, being that, neutrophil elastase is higher on that teeter-totter. Then if someone, has this genetic predisposition and then also smokes, we see that there's a huge imbalance there, leading to this emphysema, leading to this centrolobular emphysema and causing air trapping and obviously corresponding COPD. All right, so here's kind of a cartoon, saying the same thing. And then when we talk risk factors, there's lots of risk factors. And then one we like to pinpoint for COPD is tobacco smoking. Obviously, there's alpha-1 antitrypsin and environmental and occupational exposures and things like that. And then probable causes such as, things like age, male gender, low socioeconomic status, things like this. But those are a little of the risk factors. But before I kind of sign off here, I want to leave you guys with the poll so that I can, let's see, I'm going to relaunch this for you. So do me a favor, throw in your answer there now that we've kind of finished up here. And just to kind of get a gauge on where you guys are at now that we kind of talked up through a little bit about spirometry and all of these things. And then, similarly, I'll give you guys a couple seconds to kind of fill out your answers here, but I will stick around. As always, it's been a pleasure. Teaching you guys. This is always, absolutely one of the highlights of my week. I enjoy doing this. I'll stick around if you guys have any questions at all. Otherwise, it's been a pleasure. I think I'm teaching again in a couple weeks. I'm doing kind of this every other week thing right now. So if you guys have any questions, I'll stay on for a little while so that you guys can ask those, but let me end this poll here and share the results. It looks like most of you guys had indicated that you know a little bit or some now, which is very humbling for me. I appreciate your guys' time. If you have any questions, please let me know. Are these patients candidates for lung transplantation in a long-term perspective? That's a great question. I think that for the alpha-1 antitrypsin, depending on, how severe their disease are, perhaps they are. The thing about lung transplantation in general is even if you get a lung transplant, the time that the lung transplant typically lasts is about a year, because we know that the lungs are very immunologic and there is a high risk of rejecting lung transplants. So, you know, primarily what we see is that the alpha-1 antitrypsin is treated upfront with medical management as opposed to, you know, lung transplantation upfront. I hope that answers your question. I don't know, kind of, that's a great question in terms of, you know, are they, you know, candidates for lung transplantation? I'm not entirely sure of that, you know, myself. I imagine it has to do a lot with the kind of severity of the disease.